Okay, so hello, good day. So today I will be discussing oral anti-diabetic agents. So just a few disclaimers. Number one, medicine is an ever-changing science. So all of this information is based on today, which is April 16, 2024. There could be changes in the studies on different drugs, especially that we will discuss here, since there are so many trials that are ongoing with regards to current and also novel anti-diabetic drugs. And number two, any um, examples of brands that I will mention here is not intended for any endorsement or commercial purposes. Okay, so essentially, we will be discussing the non-insulin medication, since there's a separate lecture that is given for the insulin, no? And the insulin analogs for pharmacology. So essentially, if we will look at other anti-diabetic agents, not just oral, but essentially also parenteral non-insulin drugs, there are, you can divide it into 6 groups depending on its particular action. So we'll go first to the insulin secretagogues. So these drugs primarily stimulate insulin release. So there are two classes of drugs under this mechanism of action. The first one would be sulfonylureas. So sulfonylureas, they bind to a particular SU receptor here, the SUR1, which is a receptor associated with ATP-sensitive potassium channel. So when the drug binds to that receptor, it inhibits the efflux of potassium cations out of the cell, which leads to depolarization, and eventually it opens up the calcium channel, causing influx of the calcium and cations, and there's a release of the preformed insulin in the pancreatic beta cells. So that would increase insulin in the body, and it will help lower down plasma glucose. This type of or this class of medication is primarily metabolized by the liver into weakly active or inactive compounds, no, except acetohexamide. Um, and then those metabolites are eventually released or excreted by predominantly the kidneys. So there are two generations, no, of sulfonylureas. The first one would be the older ones would be including the tolbutamide. It is a well-absorbed drug, and it is rapidly metabolized in the liver. As you can see, its duration of action is in within 6 to 12 hours. One of its so-called advantages, it has a short duration of effect. Therefore, the chances of hypoglycemia, in relation to this drug would be much less common or rare compared to other oral anti-diabetic agents. Its half-life is around 4 to 5 hours. So it is usually given in divided doses because of its pharmacokinetic characteristics. Another one would be chlorpropamide. So it is also well absorbed, and its onset of action would be much longer. It usually takes about 2.5 days. Okay, but its effect can be felt, or its glucose lowering action can be perceived as early as 3 hours. Okay, it has also a longer half-life, which is around 36 hours. So this allows once a day dosing as compared to tolbutamide. Tolzamide and acetohexamide are no longer available locally in most Western countries. So I won't discuss further those two medications, and it's not currently popular, as a drug of choice when you manage diabetes. So other sulfonylureas would fall into the second generation. So they say it is 100 to 200 times more potent than the first generation. However, because of its longer pharmacokinetic characteristics, its use has to be cautious in elderly and those with cardiovascular diseases. Okay, because of its higher potential for hypoglycemia because of its relatively higher potency. So some of these drugs include yung glyburide, or locally we know this as glibenclamide. So it has a high protein bound activity, about 99%. This is also metabolized in the liver, but the unique characteristic of this is that 50% of the metabolites is excreted in the kidneys, 50% is excreted in the feces. So it's very relatively equal as compared to the other sulfonylureas, wherein its majority or primarily excreted renally. So it would be more difficult to give these drugs, especially in patients with chronic liver disease. It has a half-life of around 16 to 24 hours, so it also allows a once-a-day dosing. And it can be in combination also with other medications, or it can be started as a monotherapy. Glipizide is another drug which is a rapidly absorbed with a 100% bioavailability. It has the shortest half-life among the second generation, which is around 2 to 4 hours. Therefore, again, similar to yung chlorpropamide, it has a lower chance of hypoglycemia. So food delays absorption. So sulfonylureas are ideally taken around 30 minutes, no, prior to meals. It also could work, no, in delta and alpha cells in the pancreas. Therefore, it also stimulates somatostatin secretion, which suppresses glucagon release. So that's again another glucose lowering mechanism that glipizide can be advantageous, no, for management of diabetes. So this is usually preferable among elderlies, wherein the pharmacokinetic effects could be much more unpredictable, and it could also prolong the effect of other medications, which would make them more prone to hypoglycemia with these types of medications. Another second generation SU would be glimepiride. So it also has a good bioavailability, around 90%. Its peak plasma concentration is around 2 to 3 hours after intake. The half-life is relatively short also, around 5 to 9 hours. But the duration of action can be as long as 24 hours. So this allows a once or twice a day dosing for this drug. As you can see here, 60% is eliminated through the kidney, and 40% is eliminated through the feces. Not seen here in this slide would be in gliclazide, which also has a good bioavailability of around 90%, peak plasma 4 to 6 hours with extensive metabolism in the liver. Its duration of action is around 10 to 24 hours also, and again, predominantly excreted by the kidneys at around 80%. One of the disadvantages of sulfonylureas is that they have the tendency to cause weight gain as compared to other medications. And that would be a very important thing to consider, no? Especially since there are a considerable fraction of diabetics that are also obese. And therefore, weight loss, which could be one of the aspects in the management of diabetes, sulfonylureas may have a limited use, no, in these subgroups of patients. Okay, the second class would be yung mga biglitinides. Okay, so there are two main drugs under this class. Would be, the first one is repaglinide. So in a way, they have a similar mechanism of action. It also binds near the SU receptor. There are two common sites with the SU drugs, but there's one unique site within that receptor complex, which these groups of drugs bind to, but essentially their end action is similar, preventing a potassium efflux, promotes calcium influx, leading to the release of preformed insulin in the beta cells. So It has a fast onset of action, which is about 1 hour after intake. Duration of action is around 4 to 7 hours. It is cleared by the cytochrome P450 enzymes. It has also a short half-life of 1 hour. So usually this requires usually 3 times a day dosing. One of these advantages of this one as compared to the sulfonylureas is that it does not contain sulfur in its compound. So therefore, in patients with sulfa allergies, this would be a preferable medication or option, no? Whether some monotherapy or combination with other classes of anti-diabetic medications. Nateglinide would be a D-phenylalanine derivative. It has a 73 to 75% bioavailability. It has a very rapid onset of action within less than 20 minutes. It could now exert its hypoglycemic effect. It also has a short duration of action, 3 to 4 hours, and around 1 to 2 hours half-life. So this drug also requires multiple doses. So that's one of its disadvantages as well. So the second group of anti-diabetic medications will be those that acts on the liver, the muscle, and the adipose tissue. So the peripheral tissues, because as we all know, in the glucose metabolism, that in there's also the peripheral utilization of glucose, which is involved in the regulation of our plasma glucose in our body. So um, the drug that is known under this mechanism of action would be the biguanide, so particularly metformin. So what metformin does is it increases the adenosine monophosphate activated protein kinase activity. So what you call the AMPK, as you can see here. So in effect, this activation of AMPK, okay, decreases gluconeogenesis and lipogenesis. So metformin passes through this organic cation transport channel, OCT1, or it is also called SLC22A1, which is abundant in liver and in the gastrointestinal tract. Its half-life would be around 3 to 4 hours. It is not plasma protein bound, and this is usually metabolized also by the liver and excreted by the kidneys as an active compound. So one of the problems, as they would say here, because since it inhibits or lowers down gluconeogenesis, they say that it impairs the metabolism of lactic acid. So some has postulated that metformin is highly associated with lactic acidosis, but clinical studies have shown that the frequency of lactic acidosis associated with metformin alone is a rare occurrence, although it has a higher risk among patients with chronic kidney disease. So because it's excreted primarily in the kidneys, so the dosage of this medication is adjusted depending on the estimated glomerular filtration rates. And in cases of, for example, you would administer radio contrast for imaging studies for patients, among diabetic patients on metformin. It is ideal to discontinue the drug one day or during the day of the contrast administration, and then you would resume it around 2 to 3 days after the imaging test was performed. So that would also allow prevention of what you call a contrast-induced nephropathy or an acute kidney injury related to the drug, because the problem with radio contrast is that it can cause also acute kidney injury, since that is also excreted by the kidneys after its use for particular imaging test. Usual It is this drug is an inexpensive drug, one of the cheapest drugs available. It is given also as an initial therapy. Even in patients with CKD, it still has its use, and it has a wide experience, a long period of evidence of efficacy uh, in CKD and even in patients with cardiovascular diseases. Its primary adverse event would be gastrointestinal symptoms such as anorexia, nausea and vomiting, and diarrhea. One of the advantages of this drug would be it also promotes weight loss. So one of the problems though that it interferes also with the absorption of the calcium-mediated vitamin B12. So while it's uncommon, there could be a vitamin B12 deficiency that could also happen among patients with prolonged intake of metformin. So, but still, metformin is still one of those um, primary drugs that we use in for the treatment of diabetes mellitus. So you see here that the organic cation transport is also found in the intestinal tract and also in the kidneys. So another group that acts on these peripheral tissues would be the thiazolinidiones. Okay, so they are ligands of the peroxisome proliferative activated receptor gamma, or the PPAR gamma receptors that is found on the usually in the adipose tissues. So but they can also be found in the muscle and in the liver cells. So once it binds to these PPAR receptors, so it controls glucose homeostasis by increasing the glucose transport 4. It increases the IRS and the CAP. It also promotes a much more healthier lipid profile by increasing the LPL, apolipoprotein 2, and CD36. It also regulates the adipokines by increasing adiponectin, the fibroblast growth factor 1 and 21. It also lowers down the inflammatory mediators such as the tumor necrosis factor alpha, interleukin 6, metalloproteinases 1, and also lowers down the free fatty acids. So because of that, it increases glucose uptake, uh, it increases fatty acid oxidation, and also increases insulin secretion, therefore improving insulin sensitivity among diabetic patients. So some of the drugs involved in under this class would be pioglitazone. So it has a good bioavailability with the peak serum concentration of around 2 hours after its intake. It has a 99% protein binding capacity with a long half-life of 16 to 24 hours. So this can be given as a once-a-day medication. It is metabolized in the liver and predominantly excreted in the feces, 70%. So another one would be yung rosiglitazone, or a popular brand is called Abandia. So again, rapidly absorbed, highly protein bound, 99%, also metabolized in the liver. Its half-life is relatively shorter, so sometimes this is given twice or 3 times a week, 3 times a day, I'm sorry. And two-thirds of the metabolites is eliminated through the urine. The problem with, but before we go to the disadvantages, so there are also other advantages of TZDs. So because it's also, the PPAR gamma is also found in other organs as well. Studies have shown that it also improves the cardiac function, metabolism. It promotes vasodilation of the coronary arteries, and it regresses yung left ventricular hypertrophy, which are very important pathologic markers of coronary artery disease that would lead to severe cardiovascular diseases. It also promotes lowering of blood pressure. It improves endothelial function and lowers down cholesterol because of the improvement of free fatty oxidation in the liver. However, it does not. It also increases body weight. One of the more common adverse effects would be fluid retention. That's why it's contraindicated on patients with congestive heart failure and those with chronic liver disease, because these patients would have propensity for fluid retention because of their disease. Um, could also cause macular edema that could lead to fatal blindness. It also increases the risk of fractures and osteoporosis because of the decreased osteoblast activity as a result of the PPAR activity. Um, and it also increases yung LDL cholesterol in certain individuals. That's why initially the TCDs were the popular initial monotherapy drug uh, during the past years. But because of the eventual discovery of these um, adverse events, its use has become much more less common nowadays, but still can be an add-on therapy if the patient does not respond to the initial um, medication or a combination with the other classes of anti-diabetic medications. Okay. So now the next group or the next mechanism would be those drugs that affect gastrointestinal glucose absorption. So um, the class under this action would be the alpha glucosidase inhibitors. So alpha glucosidase promotes the breakdown of the complex sugars, the oligosaccharides, into simpler monosaccharides that could be easily absorbed in the brush borders of the small intestine, which would lead to increase in blood sugar after a meal. So because of the inhibition of this enzyme, the oligosaccharides are not maximally um, breaks down into simple sugar, so it is much more difficult to be absorbed, and therefore it lessens the chances of postprandial hyperglycemia in diabetic patients. So there are three main medications under this group. The first one would be acarbose. So as you can see, it has a low bioavailability because it's a non-absorbable drug. Um, it is primarily metabolized again through the intestines, not through the liver, but it is cleared and excreted by the kidneys as well. Although a much higher fraction would still be fecal in nature because of its action in the gastrointestinal tract. So usually you give this twice a day, and this medication should be given after the first spoonful or just right before taking your meal, because to have a much more maximal effect of lowering down glucose. Miglitol, okay, so it's another alpha glucosidase inhibitor. Um, it has a much more better bioavailability. And it is a primarily excreted renally. So this has limitations, especially in patients with chronic kidney disease. Um, and it's usually not commonly available locally. So that's why it limits its use. Voglibose, meanwhile, is usually a drug which is usually available in Asian countries and very rarely in Western countries, because this is a alpha glucosidase inhibitor which was developed or discovered in Japan, and they were able to develop this drug by isolating a particular component in a uh, streptomyces hydro hygroscopices. So that type of microorganism, um, it it has a low tissue affinity. Again, it has a primarily excreted through the feces, let's say around 95%. It also has a low bioavailability because its effect is to prevent absorption, no, of the glucose from food. So some, because of its primary effect in the gastrointestinal tract, the common adverse events of this class of medications would definitely be GI related. So from flatulence, abdominal distension, abdominal pain. Um, so it's very important um, for the patients, no, to advise these patients on the potential adverse events of not just this drug but on other oral anti-diabetic drugs as well. Now, going into the next class of drugs would be those that mimic the incretins or prolong the activity of the incretins. So remember, insulin release is higher if oral glucose is given as compared to an intravenous glucose that is introduced in the body, because in oral glucose there is a gut hormone that is released, which are called incretins, no? Particularly yung GLP-1 and the glucose dependent insulinotropic peptide or the GIP hormone. So they stimulate insulin release and also regulates blood glucose levels. It also suppresses glucagon secretion, delays gastric emptying time, and reduces, no, the apoptosis of the pancreatic beta islet. So it promotes a prolonged survival of the pancreatic beta cells in order to produce insulin. So as you can see here, once GLP-1, like all other hormones, are metabolized. So it is degraded by dipeptidyl peptide 4 enzymes, you can see here, into inactive products. And this is usually cleared by the kidneys. So that is another potential mechanism of action in order to prolong the effect of GLP-1. You have to inhibit the enzyme that metabolizes that particular substance. So that's why there are DPP-4 inhibitors that were also developed, and we have it's now available even in the local setting. There are also other medications that have stimulates directly the GLP-1. So those are the GLP-1 receptor agonists, and we will discuss them as we go along. Okay, so now let's discuss yung mga GLP-1 analog. So the first one would be exenatide. So this is usually this is a drug which is derived from the venom of a Gila monster, which is a reptile. So this is one of the initial drugs, no, that led to the discovery of the incretins, no, as an integral part of the regulation of blood sugar in our body. So it has exenatide is almost 60% structurally similar with the native GLP-1 hormone in our body. This drug is given subcutaneously. So usually it should be given an hour, no, prior to breakfast and dinner. So this is usually has a shorter half-life, but there are also other preparations now which would be extended release, so that allows a once a week dosing, which would be um advantageous, no, if you want compliance with this drug, because since it would require injection, it has the same problems, no, with that would be related or be similar with insulin administration. So this is primarily metabolized in the kidney and excreted through the urine. And then another type of GLP-1 would be the liraglutide. So it is a soluble fatty acid acylated GLP-1 analog. It has a half-life of 13 hours, sorry, which allows once a day dosing. Its bioavailability is relatively fair, around 55%. There have been studies that show that it decreases glycosylated hemoglobin, it promotes weight loss, and lowers down blood pressure as well, leading to lower risk of cardiovascular disease and mortality. So it is also metabolized through um, degradation, no, by the DPP4 and the endopeptidase. Dulaglutide, okay, has a much better bioavailability, around 65%. It is degraded by protein catabolic pathways, the endogenous catabolic pathways in the body. It has a relatively long half-life of around 24 hours, so it also allows a once a week subcutaneous dosing as well, similar to exenatide. Now, probably the most famous among these GLP-1 analogs would be the semaglutide, or um, popularly known as Ozempic. So this is a synthetic analog with a very long half-life of 1 week. So again, this allows a once a week daily dosing, and has a good bioavailability of around 90%. So locally, it is only available through injections. There's a pen readily available, so it's a fixed dose, no? Not uh, unlike the insulins that you need to adjust the number of units, no, depending on the control of the blood sugar. It has a high affinity to albumin, so and its structure is unique because there is a alpha amino isobutyric substrate, no, at a particular position in its protein. So it is much more resistant, no, to DPP4 degradation as compared to the other GLP-1 agonist, which makes it more advantageous. And again, the studies have shown that it promotes weight loss, but I would caution you that at present, it is not yet approved locally as a primary weight loss medication. This drug is only approved for the management of diabetes. Its weight loss properties is secondary only because based on the evidences and the studies uh, and the clinical trials that was started, no, on this medication, because this is a relatively newer drug, and in time we will definitely see, no, the adverse events as time goes, because there are short-term adverse events and there are long-term adverse events. Particularly, cancer would be something that they're trying to monitor, because there are some case reports that have associated cancer with the semaglutide or the other GLP-1 receptor analogs. Some of the other adverse events would be nausea and vomiting, diarrhea. It could also cause pancreatitis. Okay. So, and then for patients with what's this one? Yung thyroid malignancies or multiple endocrine neoplasias, this is contraindicated because it stimulates, no, the thyroidal cells, which could promote further hypertrophy or growth of the thyroid gland. Okay, so next would be this one, the SGLT2 inhibitors. So SGLT2 inhibitors are it acts on a particular receptor in the proximal tubules. So remember, in the glomerulus, glucose is freely filtered out. and then uh, similar to the other electrolytes and water as well. Now, there's a process of reabsorption that occurs, no, in the different segments of the tubules, as you've learned in physiology. So, glucose can be reabsorbed in the primarily in the proximal segment tubules, in the S1, S2 segment, via the SGLT2 channel. So, it promotes the re-entry, no, of blood glucose in the body. Now, by inhibiting this channel, you're also inhibiting the reabsorption of glucose and therefore promoting glucosuria, which is another effect that would lead to lowering down of blood glucose. So there are four main drugs under this class. So the first one would be the first one, the earliest, the one that was approved, no, in the European uh, FDA would be the dapagliflozin. Okay, so as you can see here, it has a high selectivity to SGLT2. It is given once a day, given the half-life is 13 hours. Canagliflozin is also the same. It's usually given also once a day. It has the lowest selectivity in SGLT2 among these four medications here. Empagliflozin, again, once a day dosing, and it has the highest SGLT2 selectivity among these medications. And the newest one is ertugliflozin. I think it's not yet available locally. And again, this is given once a day, similar to other SGLT2 inhibitors. So, in terms of bioavailability, ertugliflozin is the highest one. Um, the plasma protein binding of these medications are relatively high. They are metabolized in the liver through conjugation, and majority are majority of the metabolites are excreted renally. So SGLT2 inhibitors are at present contraindicated in patients with estimated GFR of less than 30 ml per minute. So that's the limitation of this drug. But however, SGLT2 inhibitors has become a popular medication because latest studies have shown its superiority in terms of reducing cardiovascular outcomes. So, like the canagliflozin in its Canvas study, it showed decreased death from cardiovascular events and even non-fatal MIs and stroke. For empagliflozin, it also reduces hypertensive heart failure and death from other cardiovascular causes. For dapagliflozin, in the DECLARE-TIMI study, it also reduced heart failure and cardiovascular disease with positive effects, no, on lowering down the low-density lipoprotein and high-density lipoprotein cholesterol. Ertugliflozin, this one, it's the study still, I have no idea if the study has been released, but while for most SGLT2 inhibitors, the cutoff would be 30 ml per minute, as I mentioned earlier, ertugliflozin is contraindicated in a much higher GFR levels because of its limitation based on the current evidence available. And hopefully there could be future studies that would involve its use in much more severe stages of chronic kidney disease. So how about other medications? So other medications would be here, pramlintide. This is well commonly available in locally. So pramlintide is usually an adjunctive treatment. It's not given as a monotherapy. So it's a amyloidomimetic, which is an analog of amylin. So it has multiple effects. So it goes to the brain, it inhibits the appetite centers, so it suppresses the appetite. Two, amylin can also has receptors in the gastrointestinal tract, so it slows down gastric emptying, and also it affects the absorption, no, of glucose in the intestine, so it therefore helps down lower the plasma glucose. Uh, it also acts in the pancreas by inhibiting glucagon release. Therefore, by decreasing glucagon levels, it promotes the breakdown of glycogen to release glucose to the liver. So this is given a parenterally, subcutaneously. It has a low bioavailability. That's why it's given subcutaneously. It's primarily metabolized by the kidneys and excreted through the urine. So major adverse events would include GI symptoms and hypoglycemia as well. Okay, Colsevelam meanwhile is a bile acid sequestrant. So in a similar way with alpha glucosidase inhibitors, it inhibits the absorption of in the bile acids. So it lowers down the hepatic bile acid pool. So what are its physiologic effects? So it increases the conversion of the DAG, which would promote increased insulin sensitivity. It also increases the LDL receptors, increasing its clearance of the low density lipoprotein, and lowers down uh, the bad cholesterol or the low density lipoprotein. So since again it's a primarily gas, and it affects gastrointestinal absorption, majority is eliminated in the feces. It has a very low bioavailability because it's non-absorbable agent, and it is also can be used, no, in patients with um, chronic kidney disease because its renal clearance is essentially negligible. But this is also uh, uncommonly available locally. And then the last one would be this one, bromocriptine. No? So bromocriptine is a medication that's not just used for diabetes, but also in other endocrine diseases as well, in hyperprolactinemia. It also is given in cases of infertility. So this would allow fertility, no, for couples, no. So it can be given for both male or female. So what it does is that is, as you would recall, no, in the basic physiology, dopamine levels should surge up, no, during the morning, but because of diabetes there is a lowering down of these hypothalamic dopamine levels. So bromocriptine increases, no, the hypothalamic dopamine levels. Therefore, you lower down the sympathetic nervous system activity, you lower down the glucose production in the liver, you decrease lipogenesis and triglyceride production, and also might as well also the pre-fatty acid oxidation. So at the end, you would increase glucose tolerance, increase insulin sensitivity, and lower down the triglycerides of uh, diabetics, and also has a evidence of improving the vascular endothelium, lowering down the potential formation of atherosclerosis, no, in the various blood vessels in the body. So um, it has a low bioavailability of 28%. It's primarily metabolized in the liver, and 90% of bromocriptine is excreted by feces. Okay, so most common adverse events would be nausea, fatigue, dizziness, headache, and vomiting. So those are the medications for the non-insulin medications for diabetes. So usually these medications are given for type 2 diabetes. Definitely for type 1 diabetes, insulin would be the drug of choice, because in terms of the pathophysiology, it is usually a low um, insulin production because of the autoimmune pathology of the type 1 diabetes, which limits the function of um, the beta cells of the pancreas. So that's why it's very difficult to give these drugs. You cannot even if you stimulate the sulfonylurea receptors, for example, if the insulin production is low, because in the first place there is poor beta cell number and beta cell function, um, oral medications or the non-insulin diabetic drugs would be ineffective. That's why they are used in type 2 diabetes, wherein it's usually the insulin sensitivity would be the primary problem, not necessarily insulin production. So you have to individualize the treatment for diabetes. So the American Diabetes Association has released recently a guide, no, for physicians on how to manage the type 2 diabetes. So very important again, the history taking here and physical examination. So you assess the key person characteristics. So what is the priority of the individual? You look into the lifestyle and the health behaviors of this patient. You would ask for the comorbidities of this patient, no? Presence of chronic kidney disease, heart failure, stroke, and heart disease as well. So you should also look into going beyond the physical. So are there any psychosocial issues or psychological problems that the patient may have? And you also look into the social history of the patient. So um, educational background, okay, yung occupation, okay, source of income, because even if you give, for example, you would give a GLP-1 receptor agonist, it would be very expensive medication for someone. For example, if you would give it to a uh, regular office employee, okay? So you have to consider also the cost of these medications when you're planning for treatment in patients with type 2 diabetes. So you would also ask now also yung weight, no? Also have to consider, you have also to check the weight of this patient, if the patient is obese or not, okay? And there's a diabetic patients that would be underweight on the other hand. So definitely you would avoid medications that would promote weight loss among these groups of diabetics. You should also check if there are history of adverse events in other medications, because there are other medications that could be structurally related to some of the drugs that we have mentioned here. Um, Compliance would be very important here. So you need to determine the patient's capability to follow and to be able to take, no, this medication. So the choice of oral and the subcutaneous medications, the frequency of dosing, those would be very important considerations as well. Not just the drug that is the most efficacious for diabetes. So this is a shared decision making. So this is not uh, a primarily a dictation, no, by the doctor or for the management. So you have to discuss it well with the, not just with the patient but also with the um, family, usually the caregiver as well, um, because a significant percentage of diabetes would be elderly. So you have to consider also their personal preferences, okay, and motivate them. That management of diabetes would be very important because of the complications. And no, as they would say, no one dies of diabetes per se. You die because of the diabetic related complications. So you should be able to now determine the goals. At what level you will lower down the blood sugar, because you don't want a very precipitous drop in the blood sugar, because that may cause hypoglycemia, a relative hypoglycemia in these patients. So you would also give an amount of time. So usually you give at the very least 1 month, no? Because remember, these patients have been exposed to a um, relatively higher glucose content in their blood, and an abrupt lowering could have deleterious effects for these patients. Okay, it should be realistic and achievable, and like I said, it would be time bound. So you have to also take into consideration yung lifestyle changes also of these patients. So smoking cessation, exercise, diet. So it's very important to also refer these patients to nutritionists in order to manage, the dietary plan, because it's very difficult to do that as a physician. And then eventually, um, by giving a comprehensive care of the type 2 diabetes after a certain period of time, usually 2 to 4 weeks, now you need to review your management. So monitoring, repeat laboratories, and um, follow-up assessment of these individuals. So it's a cycle wherein we prevent diabetic-related complications and optimize the quality of life of type 2 diabetic patients. Essentially, this is the same for type 1 diabetes, but uh, again, as I would mention, it's primarily management, motivating these patients on taking insulin, no? Because definitely they would, as much as possible, avoid subcutaneous or parenteral medications because of the discomfort that is involved. But there are certain instances wherein the subcutaneous or the parenteral medications would be the better option, no, for these patients. So it's a matter of convincing them uh that these medications would be better. So but if not, definitely there should be a compromise, a middle ground between the physician and the patient plus the relatives in order to optimally manage type 2 diabetes. So again, as I mentioned, by looking into the history and physical examination, so you would now look into now you can divide primarily the type 2 diabetics patients into two groups, no? The one would be the high risk and the one with a relatively lower risk. So as you can see here, the left side of this algorithm, you would this would involve patients that are high risk, of complications, or they might have already complications upon your assessment. So the primary goal of these patients is the reduction, of cardiovascular and renal disease risk through comprehensive risk management. So like for example, so let's say ito yung mga atherosclerotic cardiovascular diseases. Okay, so the patient may have already history of myocardial infarction or stroke. So usually the the drug of choice would be either a GLP-1 receptor agonist or the SGLT2 inhibitors. But again, while these are the recommended class of drugs, that doesn't necessarily mean that the other oral medications, so the other non-insulin diabetic drugs are not an option. Again, it's a good discussion between you and your patients. TCDs are options also in this case. Metformin is still its use, especially in CKD. So in our guidelines, in the International Society of Nephrology, um, we combine, metformin with SGLT2 inhibitors, no. Um, if the eGFR is less than 60 up to less than 30. And then we would look into other options now if the eGFR or the glomerular filtration rate is lower than 30, or what we call the stage 4, stage G4 chronic kidney disease. So there's a possibility of already using insulin. An option would be, again, as I mentioned earlier, linagliptin, because again, um, that that medication does not require renal dose adjustment. Mga alpha glucosidase inhibitors, they are not excreted by the kidney, so those are options. I might as well also insulin as well. So there are also other options that, while SGLT2 inhibitors or the GLP-1 receptor agonist has become the primary agent of choice, no, for patients with high risk complications, no. For those on low risk, okay, so it's very important again to discuss the goals to lower down the blood sugar. So again, yung efficacy for glucose, you would look into drugs that have depending on the efficacy of glucose lowering. So the GLP-1 inhibitors has the highest efficacy, followed by the insulins. So, and then yung mga oral medications would have also high efficacy. So, and then again, if the patient has is obese or overweight, weight management would be very important, and you have to take into consideration medications, no, that are that would have a beneficial effect on weight loss. So, as I mentioned, yung semaglutide or the Ozempic, tirzepatide, so the other GLP-1 inhibitors, the SGLT2 inhibitors, and then the DPP-4 inhibitors and the metformin would also be uh, good medications for those overweight and obese diabetic patients. So, while this is the current, no, guidelines, okay, um, you can still use other medications. So there's another guideline that would consider even the cost. So if the cost would be an issue, because like I mentioned, the GLP-1 receptor agonist and the um, SGLT2 are relatively expensive medications. You can still give TZDs or the sulfonylureas as medications, and metformin as well, no? Provided that the renal function of these patients would still be uh, in a much more better position. No? Like I mentioned earlier, it should be more than 30 ml per minute, because most of these drugs are excreted by the kidneys with the few exceptions. So, in summary, so I've mentioned 6 different types of non-insulin diabetic drugs according to its mechanism of action. I've discussed briefly how to individualize management of type 2 diabetes, and the knowledge of its different pharmacokinetic and pharmacodynamics of different drugs will help you individualize the treatment for your patient with proper communication and, again, history and PE taking of persons with diabetes. So with that, thank you for listening, and see you soon.